محاضرة اليوم حتكون باللغة الإنجليزية. أشجعكم على التواصل بخلال المؤتمر. Today I will talk to you about some recent findings illustrating the process of innovation in research in the area of autism. Autism is quite a young field and rapidly evolving. New ways of doing research are allowing us to solve problems of high relevance and impact for the community. Before I do this, I want to start by acknowledging my team members whose work I am presenting today, both on the clinical and research arms of the work that we do, as well as our research network in the province of Quebec. Let's start with some key facts about autism. Various forms of this spectrum affect over 52 million people worldwide. People with autism vary in their degree of severity and the functional impact of the condition on their development. Autism research has been a rapidly evolving area and one that has benefited from a substantial increase in global awareness and policy response that has enabled a lot more research and a lot more service and capacity development around the world. And those two areas have intersected more often than not in ways to strengthen and support services for people who are affected. In our team, we're interested in the question of the risk factors underlying autism and how those risk factors relate to outcomes throughout the lifespan. A period of interest where we've made a lot of recent discoveries is how autism looks like prior to the time of diagnosis from birth onwards. Now we have a better understanding of both genetic and non-genetic factors that interact over time, leading to variable outcomes across different individuals. These different risk factors are illustrated in this table, and we can describe them at different levels. We can describe the underlying genetic and biological factors. Some of them that can be detected even before birth and very early on in infancy. We can also describe risk factors that start appearing at the level of brain development, also prior to the onset of symptoms. And then importantly, once those symptoms start to appear, we can start identifying risk signs and later on symptoms of autism through the diagnostic process. And of course, we know that early identification and intervention in this area is possible. So this is somewhat of a complex table, but all to say that it's just a way of summarizing about a decade of research that we've done right now. And our goal going forward is to continue to study the development of autism across the lifespan of those individuals who are affected, and also to move forward in designing interventions that are scalable and usable for larger populations than we previously had done before. So some of the take-home messages that are important from this decade of doing research in this area. One is that we now know that the same set of risk factors that increase risk for autism also increase risk for a wide range of neurodevelopmental disorders like ADHD or language disorders. And those are the same disorders that overlap with autism in their diagnoses. We also know that these risk factors that lead to the condition emerging later in life start modifying development very, very early on from birth and result in a reorganization of brain networks that underlie cognition and behavior. This means that the brain is organized differently in autism, and sometimes this organization comes with key strengths that we also must be able to recognize and help people with autism thrive by building on those particular strengths that they have. So it's important to remember that those brain changes mean that children with autism perceive and learn from the world around them in different ways than typically developing children. And it's important to underscore the fact that they can learn and develop, even if that development takes a different and alternative course to what we see in typical children. These changes in the brain also are highly variable because this process of reorganization takes a different course, and autism has a different impact on different people. And so this behavioral trajectory of different individuals can be described at multiple levels. We can talk about the person's educational development, we can talk about their social development, we can talk about their adaptive behaviors. And we can't necessarily assume that the same challenges and difficulties will be the same ones across all of those domains. In other words, a child who might have severe symptoms of autism in the social domain does not mean that the same child will not have a particular strength in other domains. Going on to describe what can we do very early in life. So now we have a very established case from many years of research that shows the importance of early identification intervention and its power in improving long-term outcomes for those who are affected. What has been challenging so far, despite the fact that we recognize the importance of early intervention across the lifespan, is making those interventions scalable and available to a general population that we need them, and ensuring that each community has the capacity and potential that it needs to help those affected with autism reach their full potential. So this brings me to three ways where I think there has been a lot of improvements in the way we think about research over time, and new ways of doing things that are actually accelerating the rate of progress in discoveries very rapidly, and at the same time helping us build the necessary community capacity to address the challenges that come with autism. One of those improvements is that we now do research in larger and larger networks to be able to advance and accelerate scientific discovery. The second is that we're increasingly adopting what we call a learning health systems approach. And the learning health systems approach is basically creating a cycle that removes the traditional boundaries between research, care, and training, especially in hospital settings, and linking those hospital settings with educational programs in universities. Last but not least is that we have successful examples of a relatively new field called implementation science that's entirely focused on using available knowledge and evidence to respond to real-world problems. So I'm going to walk through some examples and illustrations of those changes in the ways we do autism, focusing on some of the work that we do in the program, which is quite a collaborative network of many people with different expertise, and of course, a lot of active participation from people from the community themselves. Starting with acceleration of discoveries through large networks. This is an example of a recent publication that we've put out where we put together a repository of EEG recordings. EEG is an easy technology that we can use with infants and children and adults alike that allows us to record brain functioning in ways that are not possible otherwise without this technology. So when we record brain functioning, we're able to understand the responses of the brain without necessarily instructing a person or using a lot of verbal skills. And instead, we can see how children respond to different stimuli and how they process the information around them in a different way. So what we did in this particular project is that we worked with 3 collaborating labs across the world in the UK and the United States, and put together a repository of over 1,400 EEG recordings collected on infants at risk for autism. Those infants were identified very early in life, before they developed autism, because they had an older brother or sister who was diagnosed with autism. And we know that around 20% of infants who have an older brother or sister diagnosed with autism will develop autism themselves over the course of childhood. So this particular risk group is been a focus of a lot of attention and research in the last decade that has taught us a great deal about how the brain changes in the early stages of infancy, leading to an autism diagnosis later on. Importantly, what we did here is that we put together data from different laboratories, because each of those laboratories can only collect a modest amount of information and enroll a relatively small number of families. But when those data were pooled together, we were able to create the first fairly large-scale repository and start advancing discovery in this way. We also developed new processing techniques that are capable of handling this much data, and ones that can address the challenges that come with having multiple data sets from different labs. And this allows us to create harmonization and comparability across these different data sets. So one of the findings that we published recently is essentially to show how those children who are later diagnosed with autism begin to be differentiated very early on in their development through measures of brain functioning. So neural coherence is one such measure that shows us how brain connectivity evolves over time. And what this graph shows is that those infants who later develop autism are distinguishable in their responses to social stimuli very early on in development. And this adds to a number of findings that show us that the process of changes in the brain happens much, much earlier, and we're able to start detecting it using those direct measurement technologies that can evolve into what we call biological markers that hopefully in the future can be more useful in the process of diagnosis. Of course, again, this work would not be possible without this building of networks and data pooling across different laboratories. Similarly, we have another project that has allowed us to follow up children through a much longer period of development, so starting from the time of an autism diagnosis and now through youth and adulthood. So in Canada, we have a project called the Pathways in Autism Spectrum Disorders, which is a project that has been running for over 10 years now across 5 Canadian provinces. And currently, we have a number of youth who are still remaining involved in this project that we have known as they grew up and developed their symptoms and how their life trajectories are now evolving. And this helps us understand how some of the risk and protective factors early on can modify those long-term outcomes in children that are affected. So just as an example of some of the discoveries that we're making here is that we're beginning to better understand how those children who start out in life with a phenomenon called language regression, that those children who experience those early delays are not necessarily ones that are going to have the same problems during school age periods. So we could not actually find an association between experiencing this, what's called a language regression early on, where a loss of speech is recorded, and later outcomes. On the other hand, some of our recent work has demonstrated that some of the same risk factors for autism also impact certain biological processes related to sleep. And we were able to show some clear associations between having problems in sleep fairly early on in development around the time of diagnosis and later ability in the area called executive function, which tends to be quite important for schooling and general development. So this emphasizes that perhaps treating some of those secondary problems that we see in autism related to sleep and nutrition are really essential to optimize healthy development into school-age children and beyond. Another example of some of the discoveries that we're making is that we're starting to ask questions related to the outcomes in mental health in those diagnosed with autism. So we know that people with autism are more likely to develop mental health problems like anxiety and depression when they grow older, but we still don't know what the process that leads to those problems looks like. So in a recent analysis, our team showed that there is an interaction between experiencing stressful life events around the school age period and the later development of such mental health symptoms, but this only related to a profile of individuals and youth who had more mental inflexibility. So in other words, stressful life events do not impact different people with autism in the same way. They modify and result in some mental health problems among those who have pre-existing problems of mental inflexibility and particularly in attention. So this might allow us to also isolate subgroups among those who are diagnosed with autism, who are more likely to develop mental health problems later on, and start supports in cooperation and close alliance with service providers who work on mental health. A last example from this pathway study that has followed up the children over 10 years is that we are developing methods to be able to capture the first-person perspectives of the youth themselves. So as the children are growing older, we're recognizing that their independent personalities and their vision about their own outcomes and life trajectory might differ from that of their parents or that of their teachers. And yet, because of the communication problems that come with autism, we're not always able to capture that information. So we recently developed some methods that allow us to deploy different strategies so that even those children with minimally verbal or those with low cognitive ability are able to share their perspectives using a variety of techniques, including use of technology and texting, as well as use of pictures to be able to express their points of view. And some of those children who are more able are also sharing with us their aspirations for how they see their life going. So one of the youth participating in our studies said that he would like to start a family that doesn't have to be fully autistic, but they need to be able to understand him, and he can understand them back. He thinks it's going to be pretty cool if all of the family were autistic, but certainly he's open to other options. So we generated some conversations with those youth that sometimes were actually quite surprising to their own families because those discussions had not been had with them. And we discovered that, beyond their verbal abilities, there's a lot of potential for getting them to articulate some of the choices and aspirations that they have for themselves in the future. Having a job, having a family, having friendships, and having a meaningful life. So we continue to work with those youth and their families now into adulthood, and we continue to exploit this remarkable data set of over 10 years to be able to advance discoveries, also through collaboration and working across the country to be able to maintain connections between the researchers and the youth participating in this project. So this wraps up some of the examples that we have of research networks that have been able to advance discovery because they're able to work with much larger groups of families and retain the engagement of those families over time. Moving on, I would like to show you also an example of a learning health system and what that means in the case of our model of integrating research with care. So as I mentioned earlier, we have a clinical arm that's led by my colleague, Julie Scora, who oversees the diagnostic clinic. And what the clinical team has done in the last few years alone is basically to set up a lifespan model where we're able to logically integrate services into different parts of our health systems that relate to the conventional one, which is always the pediatric patients, and that's where diagnosis has been mostly placed. But then those kids had been growing up and being lost through the system as they transition to the period of youth where pediatric services are no longer able to accept them. And then we recognize the complete absence of services for adults, and my colleagues and I were able to successfully develop the first adult clinic for autism in our province, which was a major accomplishment. So beyond this lifespan perspective that's equally important for clinical services as it is for research, we also are working using this model of a learning health system. So a learning health system means that clinical care and discovery can go hand in hand and mutually support and inform each other. So to achieve that, in our case, we have shared infrastructure for research and care. We do not distinguish those two processes, and we try as much as possible to maintain the focus on the family as they move between different services as well as research projects. We also have in that same space advanced technologies, including EEG and eye tracking, combined with the clinical behavioral assessments that are important for research, which reduces substantially the burden of participation on families and allows us to maximize the amount of time that we have with them. And last but not least is that an integral part of our clinical program is one focused on capacity building through training. So my colleagues often run routine courses for training on instruments like the ADOS and the ADI that are quite conventional and important for autism diagnosis. And they're also running a new type of platform called the ECHO platform that allows knowledge sharing and exchange between the different clinicians who are working with the same population, irrespective of where those clinicians sit in the healthcare system and whether they're affiliated with pediatric services or with adult services. And our center is basically the hub that brings together this community of service providers around the needs of families and helps us collaborate in the process of ensuring that they receive the care that they need. So with that, to give you just some examples of that, so when we receive families who come in at any age, the first thing that happens is that they get enrolled into a registry that is shared between clinical and research operations. And then through a process of triage, we send the families to the services that they need, and at the same time invite them to different research protocols that are interesting for them. And this allows us to share data in an ethical way between those research and service operations to ensure that the best available information, wherever it's collected, is being deployed and used for clinical decision making. In terms of capacity building, some examples of that include a partnership that we have with the Mental Health Institute that is also affiliated with our university. As I mentioned earlier, over half, at least, of youth with autism will develop some form of mental health problem. And this means that we want strong partnerships with those services that already exist and can handle and work with us to support those youth to be able to prevent unwanted consequences from these mental health problems going forward. We are also working, as everybody I think in the world, on recruiting and retaining experienced staff members who become partners in this process. And we offer consultations to all different departments of the hospital who see autism patients. So we're trying to move away from a very centralized way of delivering services towards a network of services that can support different people affected by autism, irrespective of the type of need they have, whether it's medical or related to mental health or any other specialty that they needed. And of course, we continue to offer continuing medical education and professional development, telehealth activities now during the pandemic, as well as practicums to train the next generation of clinicians to be able to serve this population better through this unique model of integration with research. So this is how we have translated this concept of learning health systems actively in our own program and removed the boundaries, the traditional boundaries that separate research from services, and also integrated training opportunities in a way that allows the next generation of professionals to more actively use this integrated model in their practice. We also are managing to gradually scale up this model above and beyond what we do in our own hospital. So we actually recently successfully started a pan-provincial collaborative network of 6 hospitals that are participating in setting up a unified registry called the Quebec 1000 Families. And this project has multiple phases, involves 12 investigators, and we will start actually this month enrolling around 1,000 families over the next 4 years across these different hospitals. And the project is organized in phases. We're in the first phase, which starts this month. Families can sign up to a registry similar to the one I described that we use in our integrated program. And then from that point forward, they get invited to different operations where in phase 2, we collect biological samples and there's a formation of a biobank, as well as a number of questionnaires that are collected from families. And we share this data with a project called Missing. This is an international repository of biological samples and sequencing data that's advancing also scientific discovery in this area and adopts an open science framework. The rest of our data also is going into a dedicated database and then combined with more advanced technologies for studying brain and behavioral development through an MRI machine that's a state-of-the-art 7 Tesla MRI machine that was developed in our imaging center and is currently being utilized, combined with other methods like the ones I described earlier in EEG and eye tracking. And what this allows us to do is have a unified framework across these different hospitals that hopefully will continue into the future, where we are building research infrastructure into university health centers, again, with the purpose of removing the traditional boundaries between research and care in the area of autism. The last example, and perhaps maybe the most, the one that we're most proud of, relates to our attempts to move science into community-based settings through this framework called implementation science, where the problems that we focus on are ones that are active problems or challenges facing service delivery in community-based settings. And we had the opportunity to develop this project in partnership with multiple service organizations also across Canada. And those service providers were selected and invited for this project, particularly because they focus on traditionally underserved populations. So traditionally underserved populations in Canada include families who are Indigenous. They also include families who might live in remote areas where there's limited services. And finally, families who are immigrants or refugees to Canada and are still having some challenges in interacting with the healthcare system. And we know that those populations, those particular subgroups, are typically neglected in our health system and they fall through the cracks. And part of our focus in this project was to work jointly with community providers who serve already this group of families to increase their capacity to provide services for those subgroups. And with the model that we decided to use is one that was developed with the World Health Organization and now being deployed in over 30 countries. And so this project itself was partnered with collaborators in the WHO and in Autism Speaks. This model is called the WHO Caregiver Skills Training Program. It addresses the widespread shortage of evidence-based interventions worldwide. It offers community professionals ongoing support from a national trainer called a master trainer in our case. And the focus of the program is really empowering caregivers with the necessary knowledge, skills, and resources to be able to directly support their children. And the program focuses on caregivers of children who are between 2 and 9 years of age, who have autism, but we do not necessarily need a confirmed diagnosis for autism for this program to be effective. In fact, we are actively trying to use this program with families who are awaiting diagnosis and suspected of having autism or a related developmental difficulty that affects social and communication behaviors. And the type of model that we used here is called a cascade training approach. This simply means that the way we achieve scalability and the way we're able to serve many more people in those communities is to train a person who's called a master trainer. So the national or regional focal point trainer are our colleagues from the WHO and a member of our team who have attained expertise in the caregiver skills training model. And in turn, those people provide support and training for a group of master trainers who are distributed across the different provinces. So we invited those different trainers across the country to receive the training. And those master trainers now, as I speak, are actually beginning to deploy this program and use it in their own services, and beginning to also train facilitators. So those are typically frontline workers. They can be community professionals like social workers, nurses, educators. Certainly they don't need to be highly specialized because those individuals would be continually supported by master trainers as they deliver the program to families. We actually started this training shortly before the pandemic. We convened for a week with approximately 20 trainers from all across Canada, and we had a fantastic week of learning and exchange and development of the training when the pandemic started. And thankfully, we were able to rapidly adapt this project and actually, I would like to say, also improve it after the pandemic through multiple adaptations that we deployed fairly quickly. One is that we launched a national survey that now has been used by colleagues across the world to better understand what was happening with families during the pandemic and to try to adjust program milestones and deliverables to be able to actively support families during this very difficult period, especially during the first period of confinement around the pandemic. We also moved fairly rapidly all of our activities using online platforms, and continued communication actually increased and intensified communication with all project participants at the time. We also developed toolkits, resources for families that we share to help them adapt to this new context of the pandemic, and to create an exchange and networking between the different people who were developing those tools. And last but not least, we also increased our policy response and collaborations to ensure that people with disability and people with autism in particular were not left behind in the pandemic response, and that their needs and rights were taken into consideration. So we essentially, as a result of all of this, redesigned the program entirely, the training program entirely, to work with the MTs in a way that allowed us to continue practice actually during the pandemic, all using online formats. And these are the different phases that we developed as an alternative to the original model. And we just completed testing of this model. We also had a lot of expressions of interest from around the world, given our connections with the World Health Organization and Autism Speaks. And we also invited other professionals who were using this model and interested in training in it. And we opened up that training to any of those professionals who had already been connected to the network, and invited them to participate in the activities to the extent that it matched their interests and their time. And these are some of the emerging results from this training period. So by the end of the training period, we initially started only with our group in Canada, which was a relatively small group, and ended up with a much larger group of over 30 therapists from these different countries who had participated to varying degrees in these various stages and milestones that we redesigned for program development, and in close collaboration and partnership with staff of the WHO and Autism Speaks, who were also delivering the training with us. And we were just able to finish analysis recently of how well those the master trainers did in acquiring the necessary knowledge and skills for autism. And we actually did find that therapists who participated reported an increase in their knowledge and confidence over the training period. We also measured their actual objectively reliability on some of the CST concepts.
شكرا لك دكتورة ميادة.